Hello everyone, this is Dr. Sam and today we will compare the images of fetal brain. These are axial images. This right here is the skull bone. This hyperechoic line is the falx cerebri. And the posterior fossa, this is the posterior fossa. And this bilobe structure is the cerebellum. And it is covered by the cerebellar vermis. And over here, this is a slightly different level, and this is the cavum septi pellucidum. It is an anechoic rectangular structure in front of the thalamus, and these hypoechoic structures are the thalami on either side of the falx cerebri in front of the cerebellum. Our first case is Ventriculomegaly. It is the abnormal dilatation of the lateral ventricles. The diameter of the lateral ventricles must be less than 10 millimeters. The choroid plexus normally occupy the majority of the space. They produce cerebrospinal fluid. And over here, the lateral ventricle diameter is more than 10 millimeters. If the diameter is between 10 to 12 millimeters, it is termed as mild ventriculomegaly. And we do not see this area clearly because of the near field reverberation artifact, which occurs due to the skull bone. Because in the upper part of the image, the ultrasound beam has higher energy. So there are large number of reflections in this area. In moderate ventriculomegaly, the size of the lateral ventricles is between 12 to 15 millimeters. As you can see, it is larger as compared to mild ventriculomegaly. In severe ventriculomegaly, the diameter of the lateral ventricles exceeds 15 millimeters. The choroid plexus are hyperechoic structures inside the lateral ventricles. They produce cerebrospinal fluid and occupy most of the space inside the lateral ventricles. In severe ventriculomegaly, a condition known as the dangling choroid plexus occurs. In this, the choroid plexus will be reduced in size and it will appear to float inside the lateral ventricle or dangle. In aqueductal stenosis, the aqueduct of Sylvius, which connects the third ventricle to the fourth ventricle, is obstructed. This leads to dilatation of the third ventricle and the lateral ventricle. The normal third ventricle will have a slit-like appearance, whereas when it is dilated, it will have a rectangular appearance. Hydranencephaly is a rare condition in which the cerebral hemispheres are replaced by large, fluid-filled cavities. I do not see any brain tissue over here, with a little bit visualization of the thalami. One way to distinguish between Hydranencephaly and severe hydrocephalus is the presence of some cortical tissue in the case of severe hydrocephalus. Porencephaly is defined as multiple cystic spaces inside the brain. Here we can see 4 separate cystic spaces. Schizencephaly presents as clefts inside the brain. There are mainly 2 types, open lip and closed lip. These clefts extend from the lateral ventricles all the way to the subarachnoid space, which means they will be reaching the skull bones on this image. In closed lip schizencephaly, the walls of the cleft are in contact with each other, which means there is no open connection between the cleft that reaches from the lateral ventricle and the subarachnoid space. There is no open connection. In the open lip type, the walls of the clefts have separation and there is direct connection from the lateral ventricle to the brain surface. An arachnoid cyst is present between the meninges of the brain, that is, in the subarachnoid space, and they do not connect with the lateral ventricles. The most common location is the parietal region, but it can also be present in the posterior fossa or the suprasellar region. This is an arachnoid cyst present in the parietal region. It is one of the most common locations of arachnoid cyst. A choroid plexus cyst is present inside the choroid plexus. As you know, the choroid plexus are hyperechoic structures. So a cyst inside a choroid plexus will have well-defined echogenic walls. Here is another image of a choroid plexus cyst. It has hyperechoic walls. Holoprosencephaly is a brain disease which has three main types. The first main type is Alobar Holoprosencephaly. In this, the thalami are fused. You can notice here the thalami are fused, whereas in the normal image they are on either side of the falx cerebri. And there is a single ventricle, monoventricular cavity, and the falx cerebri is also absent. This form is also associated with facial abnormalities. One of them is proboscis. In this, an appendage protrudes out from the forehead. This is a sagittal image showing a proboscis and appendage protruding out, which we can notice in this view. Another facial abnormality is hypotelorism. It is the reduced distance between the orbits or between the eyes. Normally it is around 1.3 centimeter, but in hypotelorism it will be lesser, and we can see the orbits, the eyes, much closer to each other. In Semilobar Holoprosencephaly, the ventricles posteriorly are partially separated, but anteriorly they are fused and have a single large monoventricular cavity as shown in this image. They are not separated, whereas in the normal view they are separated, and the falx cerebri will also be absent. Lobar Holoprosencephaly is the least severe form. In this, the thalami are normal, but the cavum septum pellucidum is absent. In agenesis of corpus callosum, the corpus callosum, which divides the cerebral hemispheres, is absent. Along with that, the cavum septum pellucidum is also absent. One classic sign is Colpocephaly, which is the teardrop-shaped lateral ventricle configuration. The ventricles are dilated and they have a teardrop shape as compared to the other types of ventriculomegaly. This one has a different shape. Interhemispheric cyst is present between the cerebral hemispheres in the midline. It occurs due to extension of the third ventricle above the level of the thalami. Anencephaly is a condition in which both calvarium and brain tissues are absent. Calvarium is part of the skull that surrounds the brain, and in anencephaly it is absent along with the brain tissue. The brain tissue is also absent. We cannot see it in anencephaly. Acrania or exencephaly is a condition in which the calvarium is absent but there is presence of abnormal brain tissue. This is the abnormal brain tissue, and this is called angiomatous stroma. When there is a protrusion of brain structures, meninges, and cerebrospinal fluid through a defect or a hole in the calvarium, this condition is called encephalocele. This is the protrusion of brain tissue and meninges, and over here the defect must be present in this area. Dandy-Walker malformation is associated with posterior fossa. There is a defect in the cerebellar vermis, which leads to fluid collection in this area. Here is a sagittal view of Dandy-Walker malformation. There is ventriculomegaly as well as posterior fossa fluid collection. In vein of Callan malformation, there is aneurysm of this vein, and on Doppler it will show turbulent flow. Right here it has mixing of colors, so it is turbulent flow. Also, this vein is having a larger diameter. Here is another image of vein of Callan malformation without Doppler. It has a larger diameter, but the best way to see it is on Doppler. Intracranial tumors are very rare, but when there is a mass seen, it is most likely a hemorrhage. This hemorrhage can appear as hyperechoic structures inside the ventricle or inside the brain tissue. They will have somewhat of a heterogeneous appearance, but mostly they will be hyperechoic. Here they will not look like choroid plexus, they will be heterogeneous as compared to choroid plexus. Intraventricular hemorrhage can cause inflammation of the lateral ventricles, which will lead to their walls appearing hyperechoic, and the choroid plexus will appear larger and have a lumpy appearance due to blood. Here is a coronal view of intraventricular hemorrhage showing hyperechoic walls of the lateral ventricles. CMV infections or infections from cytomegalovirus can occur in fetal brain. They present as calcifications in the brain tissue. Here you can see small calcifications. So when you notice such calcifications, it can be a CMV infection. Here is another example in axial view showing small calcifications in a CMV infection. Chiari-2 malformation is associated with the shape of the skull and shape of the cerebellum. The skull resembles the shape of a lemon because of flattening of the frontal bones. This is why it's called the lemon sign. Another sign is called the banana sign. This one is associated with the shape of the cerebellum. You can see the cerebellum is shaped like a banana. It is bent facing forward.
Hello everyone, this is Dr. Sam and this video is about fetal head ultrasound. The normal shape of fetal head is ovoid. The normal calvarium will be hyperechoic. We will see a bright skull, and over here we have a clover leaf configuration. It is usually associated with type 2 thanatophoric dysplasia, but it is also associated with other skeletal abnormalities. The shape of the skull is trilobed. These bulging areas on either side are bulging of temporal bones. The clover leaf configuration is caused by craniosynostosis of all the sutures. These bones join together too early and skull shape is deformed. A lemon-shaped skull occurs due to flattening of frontal bone. It is usually associated with Chiari II malformation, but sometimes is also found in normal fetus. In a strawberry-shaped skull, there is flattening of both the frontal bone and occipital bone. It is usually associated with trisomy 18. This is a sagittal view showing normal fetal forehead. And over here is a case of frontal bossing, in which there is an abnormally protruding forehead. You can see an increased convex curvature of the forehead. It is usually associated with achondroplasia, hydrocephalus, and aneuploidies. Here is another image of frontal bossing. You can see the difference in curvature of the forehead. Brachycephaly is a disproportionately wide head. The head is wider than usual. This diameter is increased. It can be a normal variant or associated with some skeletal dysplasias. Dolichocephaly is a disproportionately long head. You can see that the head is much longer than usual in this image. It can be a normal variant as well, but is also seen with breech presentation and oligohydramnios. In a fetus with osteogenesis imperfecta, hypomineralization of calvarium occurs. We do not see the normal hyperechoic skull here. It is because the mineralization of calvarium is not adequate. Hello everyone, this is Dr. Sam and today we will study fetal face ultrasound. Scanning the fetal face requires high quality equipment and experience. These are longitudinal and transverse views of fetal face. The sagittal facial profile is best for evaluating the face. We can see a lot of structures. Here is the prefrontal space in front of the frontal bone. This slanted hyperechoic line is the nasal bone. And here is the nose. You can see the upper and lower lips as well. This hyperechoic structure is the maxilla, and over here is the mandible. The transverse view can be used to view the eyes, the orbits. These small structures are the lenses. And these hyperechoic structures are nasal bones. Here is a coronal view in which we can see the nose very clearly and also the upper and lower lips. This small hyperechoic area is the chin. Cleft lip and palate is a common facial abnormality in neonates. These clefts can be unilateral or bilateral. In this image, we have a unilateral cleft lip. There is a hypoechoic defect in the upper lip. In bilateral cleft lip and palate, two hypoechoic defects can be seen in the upper lip. In this image, we can see the bilateral clefts more clearly. The hypoechoic defects are communicating with the palate. Midline facial cleft is associated with Holoprosencephaly. The face is deformed and there is absence of normal midline tissue. 3D ultrasound and MRI are much better modalities for such abnormalities. In some cases of cleft lip and palate, there is protrusion of soft tissue below the nose. We can see some protrusion of soft tissue in this longitudinal image. It is called premaxillary protrusion. Due to nasolacrimal duct obstruction, anechoic cysts may be formed. Sometimes these cysts have internal echoes. This is called dacryocystocele. These cysts are inferomedial to the orbits. We can see these cysts at the location of the nasolacrimal ducts. These are diagnosed after 30 weeks gestation. Congenital cataracts can be diagnosed on ultrasound. We will see a round hyperechoic mass in the anterior portion of the globe. In the normal image, you can see the normal lens as a small dot in the anterior part of the globe, but the cataracts are large hyperechoic masses. The distance between the medial canthi of both the orbits is called interocular diameter. This distance is approximately equal to the diameter of the eye. In hypotelorism, this interocular distance is decreased. Also, the binocular distance, that is the distance between the lateral canthi of both eyes, is decreased. You can see both the eyes are closer to each other in hypotelorism. In hypertelorism, the interocular and binocular distances are increased. The eyes are much further away from each other. Cyclopia occurs in a severe case of holoprosencephaly. In cyclopia, there is only a single midline orbit which contains either one or both eyes. We can only see a single orbit in the midline. Anophthalmia refers to absence of eyeball. In this transverse view, we can only see one eyeball. Midface is the area between the upper jaw and lower margin of orbits. In midface retrusion, an abnormal concavity is seen between the upper jaw and lower margin of the orbits. It is associated with a variety of abnormalities such as trisomy 21, Turner syndrome, and many other syndromes. Absent nasal bone is usually associated with trisomy 21. The hyperechoic nasal bone is not seen in this image, whereas in the normal image, we can see this hyperechoic nasal bone. Macroglossia refers to an abnormally enlarged tongue. It is associated with trisomy 21 and Beckwith-Wiedemann syndrome. Micrognathia refers to a small chin. It can be difficult to diagnose it because it can be subtle. Here we can see a small chin and it is not leveling with the upper jaw. In retrognathia, the chin is displaced posteriorly. It is difficult to diagnose it on ultrasound. In agnathia, the lower jaw is absent. In this image, the lower jaw is not seen. It is missing. Hello everyone, this is Dr. Sam and today we will study fetal spine ultrasound. Here are longitudinal and coronal views of the normal fetal spine. It is hyperechoic. It has a normal S-shaped curvature. Here is the thoracic spine, followed by the lumbar spine and the fused sacral spine. This is a transverse view of the spine. We will see three hyperechoic ossification centers. This is the vertebral body and these are the laminae. Shadowing is seen in front of the spine. In myelomeningocele, there is a congenital malformation of spinal cord. There is protrusion of malformed spinal cord and meninges through a spinal defect. It is covered by a thin wall. Here we see a myelomeningocele in a transverse view. There is protrusion of meninges and spinal cord here, and it is covered by a thin wall. This is a coronal view showing a spine defect. There is splaying of the posterior elements causing widening of the spine in this region. In the transverse view, the posterior elements are facing outward, whereas in the normal image they are facing inward. Diastematomyelia, which is also known as a split cord malformation, refers to an abnormality in which there is a longitudinal split in the spinal cord. We will see a hyperechoic area in the midline. This is a strong sign of diastematomyelia. Here is a longitudinal view of diastematomyelia. There is a hyperechoic focus seen in the midline. Caudal regression syndrome refers to malformation of the lumbosacral spine and the coccyx, and rarely the thoracic spine. There is a blunted, abrupt termination of the spinal cord and spine. Conus medullaris is a term given to terminal end of spinal cord. It usually ends at L1 level, but in caudal regression syndrome, spinal cord ends much higher than L1 level. It is associated with agenesis or hypoplasia of the sacrum. The sacrum is not developed normally, and the fetal legs will be in a cross-legged position. Rarely, blunt ending of the thoracic spine can also occur. Here you can see a malformation of the thoracic spine. Sacrococcygeal teratoma is a congenital tumor which originates from the sacrococcygeal region. These features distinguish it from a myelomeningocele, which has a thin wall. In rare cases of sacrococcygeal teratoma, a hyperechoic mass can be seen. Here is a large hyperechoic mass. In scoliosis, there is an abnormal lateral curvature of the spine. We can see that in this coronal view, there is lateral bending of the spine. In kyphosis, there is abnormal rounding of the spine. Anteriorly, the spine will be concave, and posteriorly it will be convex shaped. Both scoliosis and kyphosis occur due to hemivertebra, in which only one side of the vertebral body develops. Hello everyone, this is Dr. Sam, and today we will discuss fetal chest ultrasound cases. Firstly, we will study the fetal heart, and the best view to completely see the heart is the 4-chamber view, in which we can see all 4 chambers and the valves as well, and also the interventricular septum and the atrial septum, and also the foramen ovale. Here is the moderator band in the right ventricle, and this circular anechoic structure is the descending aorta. Always remember, the aorta will be very near to the left atrium. So when we locate the aorta, the nearest chamber will be the left atrium. In the left ventricular outflow tract view, we see a proper appearance of the left ventricle and the aorta, and here is the right ventricle and the posterior most left atrium, and part of the descending aorta is also seen here. In right ventricular outflow tract view, we can see the right ventricle and the main pulmonary artery, and here are the branches, the right and left pulmonary arteries. Part of the aorta is also seen. The short axis view gives us a cross section of the heart. We can see the aorta, the right ventricle, the main pulmonary artery. The IVC SVC view gives us a longitudinal view of the superior vena cava and the inferior vena cava along with the right atrium. In a ventricular septal defect, there will be a hole in the interventricular septum, and there will be a connection between the right and left ventricles. On color Doppler, we can see blood passing through this ventricular septal defect. An atrioventricular septal defect will have a large defect in the center of the heart, that is over here, and it is also known as AV canal or endocardial cushion defect. Now, because this defect is present at the level of the valves, so there will be valve abnormalities present. We can further evaluate the AVSD on color Doppler. We can see the defect at the center of the heart. In Ebstein's anomaly, there is a large right atrium but a small right ventricle, and there will be cardiomegaly, and the tricuspid valve will be displaced towards the apex because of the enlarged right atrium. Here is another case of Ebstein's anomaly showing a large right atrium, a small right ventricle, and the displacement of tricuspid valves towards the apex. In hypoplastic left heart syndrome, the left side of the heart will be smaller. We will have small left atrium and small left ventricle, and the right atrium and ventricles will be enlarged. Here is another image of hypoplastic left heart syndrome with small left atrium and ventricle and large right atrium and large right ventricle. In transposition of the great arteries, the aorta and pulmonary artery switch places. Normally the aorta and the pulmonary artery cross each other. Normally they are not parallel to each other, but in transposition of the great arteries, they have a parallel configuration. So this parallel configuration is a sign of transposition of the great arteries. In this four-chamber view, you can see the parallel configuration, which is not present in the normal view. This is a transposition of the great arteries. Here is another image showing the parallel configuration. The aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. Tetralogy of Fallot contains 4 abnormalities, which include right ventricular outflow tract obstruction, a ventricular septal defect, a right ventricle hypertrophy, and an overriding aorta. But 2 abnormalities are more easily seen. One is the ventricular septal defect, and the other one is the overriding aorta, in which the aorta will overlie this ventricular septal defect. In a double outlet right ventricle, we will see two arteries arising from the right ventricle, the aorta and the pulmonary artery. They are both arising from the right ventricle. In the case of truncus arteriosus, a single vessel will arise from the heart. Here we only see one vessel. We do not see any vessel from here, just one vessel arising from here. Ectopia cordis refers to the extrathoracic location of the heart. The heart will be outside the thoracic cavity because of a sternal defect. Here you can see in this sagittal view, the heart is located outside the chest. Sometimes the heart may have an echogenic or hyperechoic dot-like structure that will be present in the ventricle attached to the interventricular septum. This is known as an echogenic intracardiac focus. A rhabdomyoma is a cardiac tumor that usually arises from the interventricular septum. It will appear as a hyperechoic round ovoid mass. Here we have another case of rhabdomyoma, a hyperechoic round mass occupying the ventricle. A fetal diaphragm appears as a hypoechoic structure between the thoracic cavity and the abdominal cavity. In this coronal view, we see the lungs and the heart above the diaphragm, whereas in a congenital diaphragmatic hernia, there is a defect in the diaphragm which will lead to herniation of abdominal contents into the thorax, such as the stomach. Here we can see the stomach is in the thoracic cavity. The stomach will appear as a cystic structure because it is fluid filled, so it is anechoic. And here we have a four-chamber view showing the normal thorax with the heart. And here we have stomach right next to the heart, and the heart is also displaced towards the right side. Now we will discuss fetal lung abnormalities, starting with CPAM, which stands for congenital pulmonary airway malformation. It has three types based on its appearance. The first type is macrocystic, which has large cysts. They can be one or more than one, and the lung is enlarged and hyperechoic as well, and it may cause mediastinal shift. In type 2, we will have small multiple cysts scattered throughout the lung, and the lung is enlarged and hyperechoic. In CPAM type 3, we will see a hyperechoic enlarged lung without any cysts. A bronchopulmonary sequestration is defined as an abnormal lung tissue that is disconnected from the tracheobronchial tree and is a non-functioning lung tissue, and it usually appears as a wedge-shaped hyperechoic lung mass. On color Doppler, we will see a branch from the aorta supplying the sequestration. It does not receive its blood supply from the pulmonary vessels. A bronchogenic cyst is a lung cyst which appears as an anechoic cyst, and it may have internal echoes, and if it is large enough it may cause a mediastinal shift. Here is a large bronchogenic cyst in the coronal view causing mediastinal shift. CHAOS stands for Congenital High Airway Obstruction Syndrome. In this we will have both the lungs enlarged and hyperechoic, which will cause inversion or flattening of the diaphragm. Here you can see the diaphragm is inverted because the lungs are enlarged. Here we have a four-chamber view. The lungs are enlarged bilaterally and they have displaced the heart towards the center of the thorax. In CHAOS, the trachea can also be dilated. Here we can see hyperechoic lungs along with a dilated trachea. It is fluid-filled, that is why it is anechoic. Pleural effusion is the accumulation of fluid in the pleural cavity. This fluid appears as anechoic or hypoechoic. Here we can see pleural effusion in the longitudinal view. Fluid is surrounding the lungs. In this coronal view we can see bilateral pleural effusion. Fluid is surrounding both the lungs. Pericardial effusion is the accumulation of fluid around the heart. We can see this anechoic fluid around the heart. Now if the thickness is 2 millimeters or less, it is normal amount of pericardial fluid, but if it is more than 2 mm, it will be pericardial effusion. In this image we have a large amount of fluid collection around the heart. A severe case of pericardial effusion. Hello everyone, this is Dr. Sam and today we will study fetal stomach ultrasound appearances. The stomach can be visualized around 13 to 14 weeks. It is usually anechoic because it is fluid-filled and has various shapes and sizes. We can see the stomach at the level in which we see the umbilical vein. Here you can see the umbilical vein and over here you can see the stomach. This is a good level to locate the stomach. Here are more transverse views of the stomach. Here they have different shape and a different size as compared to the previous images. The filling of the stomach depends on the swallowing of amniotic fluid by the fetus. Here we can see the umbilical vein and here is the stomach. And here is the spine, hyperechoic with shadowing. A gastric pseudomass occurs when the fetus swallows skin cells, umbilical cord parts, or even blood, which may resemble a stomach mass. But it is not a stomach mass. These are just swallowed materials which look like a mass or a tumor. Here is a longitudinal view of the stomach. It appears elongated. And here is the fetal spine. The stomach is simply fluid-filled and there is no swallowed material. And over here we have the gastric pseudomass which we see in longitudinal view due to swallowed materials such as skin cells or blood or parts of the umbilical cord. And here is the fetal spine. Esophageal atresia is a birth defect in which the esophagus does not develop properly, which leads to obstruction at the level of the esophagus. Now, due to this obstruction, the stomach does not fill with amniotic fluid. That is why we may not even see the stomach. Usually this condition is associated with polyhydramnios because of improper swallowing of amniotic fluid. There is a large accumulation of amniotic fluid around the fetus. In this image we see polyhydramnios. There is a large accumulation of amniotic fluid due to improper swallowing. The stomach here is appearing small. This is due to gastric secretions. These are stomach's own secretions. That is why it is appearing small. This setting can occur in esophageal atresia. We cannot see a normal fluid-filled duodenum on ultrasound. Usually it is not visible. Only when it is dilated, it is visible. Now this similar condition can also occur with duodenum. In duodenal atresia, part of the duodenum does not develop properly. This leads to dilatation of both the duodenum and the stomach. Here we see two dilated structures. One is the stomach and this one is the duodenum. The double bubble sign is the name given to this appearance in which the stomach and the duodenum both are dilated. They appear as two bubbles, two dilated anechoic structures. This is a sign of duodenal atresia. Here is a coronal view of a double bubble sign. The stomach and the duodenum both are dilated in the setting of duodenal atresia. An enteric duplication cyst may resemble a double bubble sign or duodenal atresia, but there is one distinguishing feature, that is the stomach will not connect with the cyst, whereas it will connect with the duodenum, and also the cyst may be teardrop shaped. In congenital diaphragmatic hernia, there is a defect in the diaphragm which will allow abdominal organs to protrude through this defect and enter the chest cavity. Mostly the stomach is seen protruding through this defect, and here you can see in this coronal view the stomach is herniating through this diaphragmatic defect. In this image we can see the stomach in the thoracic cavity. The heart is displaced towards the right side because of herniation of the stomach. The stomach is no longer seen in the abdomen. Seeing the stomach in the thorax is a strong sign of congenital diaphragmatic herniation. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos. Hello everyone, this is Dr. Sam, and in this video we will study fetal bowel ultrasound images. Normally the small bowel are not visualized. Sometimes you may see fluid-filled areas in the abdomen, but mostly they are not really visible.
Here we have a transverse view and a coronal view of the fetal abdomen. In duodenal atresia, the duodenum does not form properly. This will lead to obstruction and will cause dilatation of the duodenum and the stomach. This gives us a double bubble sign, in which we see both the duodenum and the stomach as two bubbles, two dilated structures. Here we have a coronal view showing us the double bubble sign. The stomach and the duodenum are dilated. In jejunal atresia, the jejunum will be dilated because it is not formed properly during embryonic development. Here you can see the normal bowel, not really visible, and over here we have an elongated and dilated fluid-filled jejunum. Now it is different from duodenum because it is longer. Here we have another image of jejunal atresia. You can see a dilated jejunum. The diameter will exceed 7 millimeters. Dilated bowel loops can occur due to atresia volvulus, in which the intestine twists on itself, or meconium ileus, in which there is thick impacted meconium causing obstruction. The diameter will be more than 7 millimeters. Here we have another image of dilated bowel loops in coronal view. Meconium is the term given to first fetal feces. There are a number of conditions linked with meconium. In meconium ileus, there is thick and sticky meconium which gets impacted to the walls of the small bowel or even the colon. This can cause dilatation, and it can also cause echogenic bowel. Here you can see hyperechoic bowel walls, very prominent. In this image you can see dilated obstructed bowels and hyperechoic bowels as compared to the normal bowel. You can see the increase in echogenicity. Meconium peritonitis is a serious condition in which there is leakage of meconium into the peritoneal cavity. This causes shadowing calcifications as well as non-shadowing calcifications in the peritoneal cavity. Now these calcifications are usually found around the liver or around the diaphragm. Here we have a transverse view of meconium peritonitis showing calcifications. Now these calcifications can be shadowing or non-shadowing. Ascites can also occur with meconium peritonitis. Due to bowel perforation, there will be leakage of fluid into the abdominal cavity. Here we have fluid collection in the abdominal cavity. This is ascites. This can also occur with meconium peritonitis. Meconium pseudocyst is a rare complication in which we will have a hypoechoic mass with a hyperechoic calcified wall. In this image of meconium pseudocyst, we can also see internal septations and internal echoes. These can also occur in pseudocyst. In an omphalocele, there is a herniation of abdominal contents through an umbilical defect. Here we can very easily see herniated abdominal contents in this longitudinal view. The herniated abdominal contents will be covered by a membrane which is made of amnion and peritoneum. Here you can see the membrane covering the omphalocele. The umbilical cord usually inserts into the herniated contents. Usually it inserts anteriorly, but if the defect is large, it may also enter laterally. Here we have a transverse view. The herniated contents may include liver, stomach, bowel, or other abdominal organs, and ascitic fluid may also be present in some cases. Gastroschisis is an abdominal wall defect through which small bowel will be herniated and the bowel loops will float freely in the amniotic fluid. The herniated contents are not covered by any membrane. Here you can see there is no membrane and the surface is rough and irregular as compared to an omphalocele. The umbilical cord will not insert into the herniated contents. Here you can see the umbilical cord is separate from the herniated contents, and only the small bowel will be herniated. Other abdominal organs will not be herniated. Hello everyone, this is Dr. Sam and today we will study fetal kidney ultrasound. Fetal kidneys can be visualized around 14 to 16 weeks. They have an ovoid shape on transverse view and are seen on either side of the spine. Here is the spine with shadowing. This anechoic area is the renal pelvis. It is due to urine. And these hypoechoic areas are the medullary pyramids. You can also see it in the longitudinal view. And this outer layer is the cortex. Fetal kidneys can measure up to 5.5 centimeters at term. In a pelvic kidney, the kidney will be found in the pelvic region, usually around the bladder. Here you can see the kidney above the bladder, and it may also be fused with the lower pole of the normal kidney. The pelvic kidney may fuse with the lower pole of the normal kidney, and this condition is called crossed fused ectopia. Here you can see the fusion of two kidneys. In unilateral renal agenesis, there is absence of one kidney. In the normal image you can see two kidneys, whereas in this image there is only one. There is an empty renal fossa, there is no kidney present here, and this kidney is enlarged. It is usually because of compensatory mechanisms. Here we have another image of unilateral renal agenesis. We can only see one kidney here and there is an empty renal fossa. In a lying down adrenal sign, there is a linear appearance of the adrenal gland. This is a sign of renal agenesis. Here you cannot see any kidney and we only see the adrenal gland in a flat configuration. It is also called pancake, discoid, elongated, or straight adrenal gland. In this image we have Doppler analysis. Here we can see the renal vessels in this normal image supplying both the kidneys, whereas in this image we can only see renal vessels on one side. That means there is only one kidney and there is no renal vessel located here. In bilateral renal agenesis, there is absence of both the kidneys and it is a lethal condition. Here we cannot see any kidney on either side. The normal diameter of the renal pelvis is 4 millimeters in the second trimester and 7 millimeters in the third trimester. UPJ stands for uretero-pelvic junction, and UPJ obstruction leads to dilatation of the renal pelvis. Here we have bilateral UPJ obstruction. It involves both the kidneys and the ureter will be normal. It will not be dilated. In a unilateral UPJ obstruction, only one kidney is affected. This kidney is normal. We can also use the term hydronephrosis for a dilated pelvis and also dilated calyces. Here we have moderate hydronephrosis. We can see dilated calyces as well as a dilated renal pelvis on both sides. And the kidneys are hyperechoic due to dysplastic changes. There is damage to the kidneys. In a severe hydronephrosis, you can see cortical thinning. We see a very thin layer of cortex and there is a large degree of dilatation and the kidney is also enlarged. In this image we can see dilated tortuous ureters bilaterally. They appear curved and dilated. This can be due to any obstruction related to the urethra or the ureter itself. In posterior urethral valves, membranes form in the urethra, the posterior part of the urethra near the bladder, which can cause obstruction of the entire collecting system. This leads to dysplastic changes in the kidneys. They appear hyperechoic and have cystic areas. We have another case of posterior urethral valves showing us cortical cysts in the kidney. You can also notice the hyperechoic appearance of the kidney. Multicystic dysplastic kidney is a congenital disease in which we have a non-functioning kidney. The main distinguishing feature is that it has non-communicating cysts. That means that the cysts are separated from each other and are not connected in any way. This feature helps us to distinguish it from hydronephrosis, which has communicating cysts. In this image we have a longitudinal view showing a multicystic dysplastic kidney. We can see the non-communicating cysts. They are not connected to each other.
Each cyst has its own walls. In bilateral multicystic dysplastic kidney, both the kidneys are non-functioning. Here we cannot see any renal vessels on color Doppler. It is a lethal condition. In this image we have autosomal recessive polycystic kidney disease. We do not see the cysts on ultrasound because they are too small, but we do see large echogenic kidneys. In this image we have a transverse view showing enlarged echogenic kidneys bilaterally. Renal vein thrombosis is difficult to diagnose on ultrasound, but it does have some features. One of them is an enlarged echogenic kidney. It usually affects only one kidney. Hello everyone, this is Dr. Sam and today we will study fetal bladder ultrasound. Here we have the longitudinal and axial views of the fetal bladder. It is a fluid-filled structure, anechoic structure in the pelvis. And this image is with Doppler. We can see the umbilical arteries. They surround the bladder and this can be useful in locating the bladder. Fetal megacystis is the term given for abnormally enlarged bladder. In the first trimester, the diameter will exceed 7 millimeters. Here we have a transverse view showing fetal megacystis. In the second trimester, the bladder diameter will exceed 30 millimeters in the case of megacystis. And in the third trimester, it will exceed 60 millimeters. A ureterocele occurs when the ureter inserts into the bladder. It appears as a thin-walled circular structure and it usually occurs in the setting of duplication of collecting systems. The size of the circular structure can vary. Here we have another image of a ureterocele. You can see a circular structure inside the bladder. In posterior urethral valves, membranes form in the urethra which cause the posterior urethra and the bladder to become dilated. This only occurs in males and this appearance has a special name known as the keyhole sign. In prune belly syndrome, there is a very large bladder. It can even occupy the abdomen and the abdominal wall muscles are absent. Here you can see the whole bladder and this layer is also very thin. And the urethra and ureters are also dilated. Here we have another case of prune belly syndrome. In the longitudinal view, you can see a very large dilated bladder. Hello everyone, this is Dr. Sam and this video is about fetal musculoskeletal ultrasound. Most musculoskeletal abnormalities are seen in late second trimester and the third trimester. We will start by looking at fetal hand anomalies. On the left side, we can see a normal hand. The thumb and forefingers can be seen normally. This is a case of polydactyly. In this condition, there are more than 5 digits in a hand or foot. Clinodactyly is a condition in which there is abnormal angulation of interphalangeal joint. It usually affects the fifth finger. There is hypoplasia of middle phalanx, that is, this bone of the fifth finger. It does not develop properly, which causes inward angulation. In acrodactyly, the central fingers are absent. We only find a thumb and 2 other digits here. There is a separation of thumb from these fingers, which creates a gap in the middle. This is also called lobster claw hand. Here is an image of a normal fetal foot, and over here is a foot affected by acrodactyly. The central toes are missing. Only the big toe and the fifth toe are seen. A clenched hand will often look like this. If the hand remains clenched and fixed throughout the pregnancy, it may be associated with trisomy 18, which is also called Edwards syndrome. Clubfoot refers to a condition in which there is abnormal angulation of the foot at the ankle relative to the tibia and fibula. Normally, the ankle and foot must look like this. This is the proper alignment of the foot, whereas over here it appears curved at the ankle region. The foot often remains fixed in this position throughout the pregnancy. Here is another image of a club foot. The abnormal angulation is more severe in this case. Rocker bottom foot, which is also called congenital vertical talus, is a congenital anomaly in which there is a convex plantar surface of the foot. It is associated with trisomy 18, that is, Edwards syndrome. A sandal gap toe consists of a prominent gap between the big toe and the second toe. You can see the difference in the size of the gap as compared to the gap in the normal foot. Usually it is an isolated finding, but sometimes it is associated with Down syndrome. A short femoral length is associated with many types of anomalies such as growth restriction and skeletal dysplasias. The femoral length will be shorter than expected for gestational age. Micromelia is a term that refers to shortening of long bones which are present in the limbs. In the normal image, we can see a normal, well-developed humerus, whereas in this image, we see a small humerus as well as small radius and ulna. On the left side is an image of a normal thorax in sagittal plane, and on the right side is a small thorax. A small chest will look like this. The abdomen is protruding out as well. This appearance is associated with lethal skeletal dysplasias. Osteogenesis imperfecta is a congenital disorder which affects bones and connective tissue and has many features on ultrasound. The calvarium has decreased ossification. It is not hard enough and becomes softer than usual. The normal calvarium has some posterior shadowing, and we cannot see the brain anatomy in the near field of the image. But in this case, the skull bone is soft, which allows us to see more brain detail, and there is no shadowing. Also, the skull can become deformed with probe pressure. This disorder also causes fractures in long bones. We may find a fractured femur, which will look like this. In this image, we see a fractured humerus. You can see a disruption in the bone right here. Thanatophoric dysplasia is the most common lethal skeletal dysplasia. Fractures along with short and thick long bones are found. This is a short, thick femur with a fracture. This is an image of the tibia. It is shorter in length and thicker than usual. It is difficult to evaluate the tibia as compared to the femur. Thanatophoric dysplasia also consists of a clover leaf configuration of the skull. This is how the skull shape will look like. It is called the clover leaf shape. On the left side, we can see normal soft tissue thickness in the legs, but in the image on the right, there is increased soft tissue thickness in the extremities. If we find all or most of these features, we can diagnose thanatophoric dysplasia. Achondrogenesis is a rare skeletal dysplasia. It has a variety of features. The most common one is absent spine. This is a normal image of the fetal spine in sagittal view. We can see a well-developed hyperechoic spine. But in this image, we do not see any hyperechoic spine. The vertebral bodies are absent. This is due to vertebral body demineralization. Nuchal edema is another feature of achondrogenesis. Normal nuchal thickness looks like this in transverse view. It is measured when we see the cerebellum. In this image, we see an increased nuchal thickness. This is due to nuchal edema. It is very prominent. The skull bone is developed normally, but since the spine is absent, this appearance collectively is called the floating head appearance. Rib shortening is another feature of achondrogenesis. The normal ribs are seen here. They are also producing some shadowing on the sides. But in this image, we see short ribs and no shadowing on both sides. This image shows us the normal chest and abdomen. The next feature is a protuberant abdomen. It is bulging out. It usually occurs along with a small thorax. Achondroplasia is another common skeletal dysplasia. A trident hand is one of its features. You will find a prominent gap between the third and fourth digits. A short femur is also a feature of achondroplasia. The femoral length is shorter than expected for gestational age. An abnormally protruding forehead is also associated with achondroplasia. It is called frontal bossing. The forehead has an abnormally increased convex curvature, which is not seen in normal cases. In a depressed nasal bridge, the top part of the nose sinks deeper. It can also affect the forehead if it occurs. The forehead may also be depressed. Arthrogryposis involves fixed joint contractures with absent fetal movement. We will not find movement of the limbs. You will see fixed joints and stiff arms and legs, which will not change their position throughout the pregnancy. This is an image of the arm. It has remained in a fixed position throughout the pregnancy. Amniotic sheets are thick bands of amnion that are connected to the uterine wall. They do not cause any deformities in the fetus because they do not trap any fetal part. On color Doppler, internal flow can be detected. Amniotic band syndrome occurs when the amnion is disrupted from the chorion and is able to float around freely. This free-floating amnion may trap any fetal parts. This can cause deformities in the trapped part and can even lead to fetal demise. Usually, it affects the fetal limbs. It can even cause amputation of toes and fingers. If fetal head is trapped, it can cause anencephaly and fetal death. If the abdomen is trapped, it can cause hernia and abdominal wall defects.
Hello everyone, this is Dr. Sam and today we will discuss the ultrasound appearances of placenta. The placenta is an organ that supplies blood to the fetus. It starts forming around 11 weeks of gestation age and it is well visualized by the end of first trimester, that is 13 weeks, appearing as an echogenic structure. The normal thickness is between 2 to 4 centimeters. Here you can see small hypoechoic areas inside the placenta. These are venous lakes or placental lakes. These are normal occurrences, and you may also notice a hypoechoic layer behind the placenta. This is known as retroplacental layer. A subcenturiate lobe is an accessory placental lobe which will be present in addition to the main placental lobe. Here we see the main placenta and an accessory placental lobe, the subcenturiate lobe, without any connection between the two. A thick placenta will have a thickness of more than 4 centimeters and it can occur in many conditions such as gestational diabetes, infections, placental hemorrhages, maternal anemia, or placenta accreta. In the setting of severe polyhydramnios, the placenta can be compressed and have a thickness falling below 2 centimeters. Then it will be a thin placenta. A thin placenta can also occur with diabetes, and hypertension. A circumvallate placenta will have raised rolled edges. This raised rolled edge is known as a placental shelf. This gives it a club-like appearance. Normally, the amniochorionic membranes attach to the edge of the placenta, but in this situation, they attach on the interior surface of the placenta. Here is another case of circumvallate placenta. Here we can see the raised and curved edges. Examining the location of the placenta is very important in determining whether the patient will have a C-section or a normal delivery. Over here is the cervix, and this junction is the internal cervical os, and you can see the fetal head. This is good because the fetus is in cephalic presentation. And over here we have the placenta that is very near the internal os. We have to measure this distance between the internal os and the placental margin. If it is less than 2 centimeters, then this is a low-lying placenta, and a C-section will be needed. When the placenta overlies the cervix, it is known as placenta previa. The first type is the marginal placenta previa. In this, the placental edge or the placental margin will overlie the cervix, but it will not cover the internal os. In partial placenta previa, the placenta will partially cover the internal os. Here only the inferior part, this part right here, is covering the internal os. In complete placenta previa, the placenta will completely overlie the internal os. Here you can see the placenta is overlying the internal os. Now we move on to placenta accreta. It is the abnormally deep adherence of the placenta in the uterus. It has 3 types based on its severity. The mildest form has the same name, placenta accreta. It is the mildest form in which the placenta adheres deep into the endometrium but does not invade the myometrium. The second moderate form is placenta increta, in which the placenta will invade the superficial part of the myometrium but not deep into the myometrium. The most severe form is placenta percreta, in which the placenta will invade deep into the myometrium. The first 2 forms are hard to visualize on ultrasound, but the most severe form has some features such as non-visualization of retroplacental layer, which is hypoechoic. Here we cannot visualize that layer. We can notice this feature around the bladder. Over here you can see the hypoechoic layer, but here it is absent. Another feature of placenta percreta is the presence of hypoechoic spaces inside the placenta. These are called lacunae. They are different from placental lakes as they appear larger in size and have an irregular shape and are comparatively more in number. On color Doppler, we will see
hypervascularity in the serosal layer, that is the outermost layer of the uterus, and usually we will see this hypervascularity around the bladder region. Here is another image showing increased vascularity in the serosal layer. Placental abruption is the premature separation of the placenta from the uterine wall. It is very difficult to diagnose it on ultrasound, as it can be confused with other conditions such as retroplacental hematomas, but it has a few features. One of them is a crescentic hypoechoic area behind the placenta with internal echoes. A preplacental hematoma occurs due to injury leading to hemorrhage, which gives us a heterogeneous fluid collection inside the placenta due to bleeding. A subchorionic hematoma can resemble a placenta, as the bleeding occurs below the chorionic layer. It elevates the amniochorionic membranes, but they have one distinguishing feature, that is this hyperechoic line. This line is of the amniochorionic membrane, and a fresh hematoma will appear echogenic. Over a period of time, around 10 to 11 days, the hematoma will have a hypoechoic appearance. This change in appearance can distinguish it from a placenta. And also another feature is that on color Doppler, the hematoma will not have any internal flow, whereas a placenta will have internal flow. Infarcts in the placenta appear as hypoechoic areas, but one distinguishing feature is that they have a hyperechoic bright rim. In this image you can see two infarcts. They are hypoechoic and have a hyperechoic rim. One common benign tumor of the placenta is the chorioangioma. It appears as a round ovoid mass inside the placenta. Another image of chorioangioma showing a round ovoid mass in the placenta. Usually it is hypoechoic as compared to the placenta. On color Doppler, we will see large blood vessels supplying the mass. We can see both the arteries and the veins. It has a very large blood supply. Here is another Doppler image showing large vessels supplying the chorioangioma. Hello everyone, this is Dr. Sam, and in this video we will discuss placental grading on ultrasound. Placental grading is done through the visual appearance of the placenta on ultrasound. It has 4 grades ranging from grade 0 to grade 3. The placenta is well visualized by the end of first trimester, that is around 13 weeks, and it has 2 sides. The side that is facing the fetus is the chorionic plate, and the side that is attached to the uterine wall or the maternal side, this area is the basal plate. From the formation of placenta till around 18 weeks of gestational age is the placental grade 0. The echo texture is smooth and there are no internal calcifications inside the placenta,
and the chorionic plate is also smooth. Placental grading usually is based on calcifications and indentations in the placenta. From 18 to 29 weeks gestational age is placental grade 1. There will be few calcifications, but the basal plate will not have any calcifications. There will be no echogenic area in the basal plate, and there will be indentations at the chorionic plate. These are the indentations, these notches or curves. We will start to see these indentations. Here are more images of a grade 1 placenta. Here it is bright due to enhancement because of amniotic fluid, and over here you can see no hyperechoic area at the basal plate, and there are few hyperechoic areas. These are calcifications in the placenta, and here are few indentations at the chorionic plate. A grade 2 placenta is from 30 to 38 weeks of gestational age. There are calcifications at the basal plate, and the indentations are much deeper, and these indentations are comma-like indentations, and there is increased calcification in the placenta. Now the placenta may remain at grade 2 until delivery. Sometimes the calcifications can be appearing as hyperechoic lines going through the placenta all the way to the basal plate. And here are the indentations at the chorionic plate. Sometimes the placenta may enter grade 3, which is around 39 weeks. There is diffuse calcification and diffuse echogenicity, and acoustic shadowing may also be present due to increasing calcifications. Here are more images showing grade 3 placenta with diffuse calcifications and hyperechoic areas throughout the placenta. Here are more images of a grade 3 placenta. If the placenta shows this type of appearance, let's say for example 20 weeks or before grade 3, that is before 38 or 39 weeks, this may be a sign of placental insufficiency.
Hello everyone, this is Dr. Sam, and this video is about placental thickness for estimating gestational age. We can use placental thickness to get an approximate gestational age. For this method, the placenta and fetus must be normal and healthy. By the end of pregnancy, the normal thickness will reach around 4 centimeters. The thickness of placenta in centimeters will be equal to gestational age in weeks, approximately. These images of placenta are just used as examples. In the first image, placental thickness is 15 millimeters. So the gestational age will be 15 weeks approximately. In the second image, the placental thickness is 20 millimeters, so the approximate gestational age will be 20 weeks. Gradually, the placental thickness increases. It is said to increase by 1 millimeter per week. Here it is 25 millimeters, which will correspond to a gestational age of 25 weeks approximately. And over here we have a posterior placenta with a 30 millimeters thickness. This corresponds to 30 weeks approximately. An anterior placenta such as this one will be slightly thinner. It is less likely to reach 4 centimeters in maximum thickness. Usually an anterior placenta will reach a maximum thickness of 3.3 to 3.4 centimeters. Here we can see the placenta is thick. The thickness is 32 millimeters, which corresponds to 32 weeks gestational age approximately. And finally, this placental thickness is 39 millimeters and it corresponds to 39 weeks gestational age approximately. Hello everyone, this is Dr. Sam and this video is about normal placental positions on ultrasound. An anterior placental position is the most common position. The placenta attaches to the anterior wall of the uterus. In the longitudinal view, it will be seen on the upper side of the image taken transabdominally. The fetal position will usually be a back-to-back or an occipito posterior position. That means the fetal head will be down towards the cervix and the back of the head and the fetal spine will be against the mother's spine. In a posterior placenta, the placenta attaches to the posterior wall of the uterus. The placenta will be seen in the lower half of the image in longitudinal view taken transabdominally. In a fundal placenta, placental attachment is at the wall of the fundus. It is attached to the upper part of the uterus. In a transabdominal longitudinal view, the placenta will be seen on the left side of the image. We can see a curved placenta attached to the fundal wall of the uterus. And finally, a lateral placenta is attached to either the left wall or the right wall of the uterus. This position is less common than other placental positions. In this image, the placenta is attached to the right wall of the uterus, and in this image, it is attached to the left wall of the uterus. Hello everyone, this is Dr. Sam, and today we will study umbilical cord appearances on ultrasound. The umbilical cord connects the placenta to the fetus and provides blood supply. Here we can see a cross-section of the umbilical cord. It is the transverse view. We can see how many vessels it contains. The one with the larger diameter is the umbilical vein, and these two with smaller diameters are the umbilical arteries. So we have 2 arteries and 1 vein. And the umbilical cord is protected by a substance known as Wharton's jelly. And over here we can see the umbilical cord entering the fetus at the umbilicus on the abdomen. Sometimes there may only be a single umbilical artery present. Here we can see only one umbilical artery in transverse view in its cross section. On color Doppler, we can further investigate a single umbilical artery. First, we need to locate the bladder, and we can see the umbilical arteries on both sides of the bladder, the lateral sides. These are the umbilical arteries. They carry deoxygenated blood from the fetus to the placenta. So this blood is going out of the fetus, away from the fetus towards the placenta, and it is going away from the probe. So that's why we have a blue color in Doppler. And over here we can see
one umbilical artery is missing. The color Doppler shows flow on only one side of the bladder, so this is a single umbilical artery. Now we move on to umbilical cord insertion. Normally the umbilical cord should enter the placenta at its center, but in the case of eccentric cord insertion, the cord enters the placenta near the placental edge instead of the center. Here is the placental edge and it is entering near the placental edge. In marginal cord insertion, the umbilical cord enters the placenta at its margin or the placental edge instead of the center, and the eccentric cord insertion will be over here. A filamentous cord insertion is a more serious abnormality in which the umbilical cord will insert into the amniochorionic membranes instead of directly into the placenta. The blood vessels travel through these membranes and then reach the placenta. These blood vessels are not protected by Warden's jelly. That's why they are more prone to rupture. In this image, the umbilical cord is inserting into these membranes, and here is the placenta. So this is also a filamentous cord insertion. A vasa previa occurs when there are fetal vessels overlying the internal cervical os. These blood vessels are also not protected by Wharton's jelly. Now it is different from a phonic presentation in which the umbilical cord overlies the cervix. We can see the umbilical cord moving and floating in the amniotic fluid, and we can also see the Wharton's jelly, and this presentation may resolve over time. Whereas in vasa previa, we do not see any part of the umbilical cord floating in the amniotic fluid. Here is a transvaginal view showing a normal image and a vasa previa. Here there are fetal blood vessels overlying the internal cervical os, and in the normal image there will be no fetal blood vessels present here. Umbilical cord cysts can also occur. Most commonly they occur in the first trimester. Here in the normal image you can see a normal umbilical cord, and over here you can see an anechoic cyst with a hyperechoic border. This is an umbilical cord cyst. Umbilical vein varix is a focal dilatation of the intra-abdominal part of the umbilical vein. We will see an anechoic structure near the bladder. This is the dilatation of the umbilical vein, and it usually measures around 9 millimeters in diameter. When we apply color Doppler, we can see internal flow and we can distinguish it from a cyst. A persistent right umbilical vein occurs when the intrahepatic component of the umbilical vein curves towards the stomach instead of curving to the right side. Here you can see the umbilical vein curving towards the right side, and over here it is curving towards the left side, towards the stomach. Hello everyone, this is Dr. Sam, and in this video we will study umbilical artery Doppler. It is not recommended to perform Doppler study in the first trimester and early second trimester due to heating issues. Because of high intensity of Doppler ultrasound, it can be harmful to the fetus. Mostly it is performed in the third trimester. We can perform Doppler study at 3 locations by placing the sample volume at specific points. The first is the placental end of the umbilical cord. Second is the free cord that is floating freely in the amniotic fluid. The third is the fetal end, where the umbilical cord enters the fetus. But the placental and the fetal ends are difficult to perform Doppler analysis. That is why the free cord is sufficient for Doppler study. We can locate the umbilical artery in the cord by applying color Doppler, and then we can place the sample volume in the red or the orange zone because it is indicating that the blood is traveling towards the placenta, and the umbilical artery carries blood towards the placenta, so we can place the sample volume over here. And the pattern that we see in spectral Doppler is the sawtooth pattern. The vertical plane on the spectral graph indicates velocity. The highest velocity is known as peak systolic velocity, and the lowest velocity is called end diastolic velocity. This is a normal cardiac cycle in the umbilical artery, and it is the normal pattern in spectral Doppler for umbilical artery. There are a number of parameters that are helpful in diagnosing vascular diseases. The first one is the ST ratio. It is the ratio between peak systolic velocity and end diastolic velocity. It is a measure of resistance to blood flow. If there is a higher resistance to blood flow, the ST ratio will be higher. In certain maternal conditions such as diabetes mellitus or hypertension, or if we suspect fetal growth restriction, a Doppler study may be performed in the second trimester. The normal ST ratio at 20 weeks is 4, and by 30 weeks it is 2.8, and it further decreases to 2.1 at around 39 to 40 weeks. This shows us that blood flow resistance decreases over time. The pulsatility index formula is PSV minus EDV divided by time average velocity. It is also used in measuring resistance to blood flow, and it decreases over time as well. The resistive index is calculated by this formula, PSV minus EDV divided by PSV. It also decreases over time. Now we will compare the normal spectral Doppler to the abnormal spectral Doppler of umbilical artery. In reduced end diastolic flow, the EDV is low. That means the end diastolic velocity is reduced. The ST ratio and resistive index are higher. This indicates that there is resistance to blood flow, and it may indicate placental insufficiency. The ST ratio is very high, 7.3, and the resistive index is also high. It is 0.86. Here we have another example of reduced end diastolic flow. The ST ratio is 5.3 and the resistive index is 0.81. In absent end diastolic flow, the EDV is 0. You can see the difference in EDV. The diastolic velocity is 0, and if spectral analysis is performed around 16 weeks, that is normal because at this stage the resistance is higher. So it is normal to see this graph in 16 weeks of gestational age. But if this is seen in the third trimester or after 16 weeks, then it is a sign of placental insufficiency. The resistive index is 1. It is high. Here we have another case of absent end diastolic flow with 0 diastolic velocity and indicating placental insufficiency. In reversed end diastolic flow, we see flow reversal. We can see the velocity below the baseline, which indicates that there is reversal of flow due to high resistance, and this indicates intrauterine growth restriction. But this pattern is normal up to 16 weeks. But after 16 weeks, it can indicate intrauterine growth restriction. In this image, you can also see velocity below the baseline indicating flow reversal. This is a sign of intrauterine growth restriction. Hello everyone, this is Dr. Sam, and today we will study ductus venosus Doppler ultrasound. Ductus venosus connects the umbilical vein to the inferior vena cava. It carries oxygenated blood and it bypasses the liver circulation. It has a triphasic pattern on spectral Doppler. It exhibits forward flow. There are 3 specific points on this pattern. The highest peak is called the S wave. It represents ventricular systole. There is a sharp increase in velocity for a short amount of time. The second highest peak is the D wave. It represents early diastole. And the A wave is the lowest point and it represents atrial contraction. The entire blood flow is in the forward direction. The A wave is more important in diagnosing certain conditions such as placental insufficiency, IUGR, and cardiac anomalies. In the first image, you can see a normal ductus venosus. At 18 weeks, you can see the A wave is normal, whereas in the second image, it is taken at 24 weeks of the same fetus, and you can see a reduction in the A wave. It can be a sign of placental insufficiency and IUGR. A wave reversal is definitely abnormal. Here the A wave is seen below the baseline. It is in the same fetus taken at 25 weeks. It is a sign of cardiac dysfunction, and there is dichotomy between S and D wave, which means the S and D wave are almost at the same level and closer to each other. Here we have another case of reversed A wave. The A wave is below the baseline, which indicates flow reversal. Now this can be associated with cardiac anomalies, trisomy 21, that is Down's syndrome, preeclampsia, or gestational diabetes. Hello everyone, this is Dr. Sam, and today we will study Doppler ultrasound of fetal middle cerebral artery. On spectral Doppler, there is high resistance antegrade flow. Antegrade is forward flow. We can see the high resistance flow by looking at the velocity. Here the end diastolic velocity is very low. It is like less than 10 centimeters per second. The normal ST ratio of MCA must be higher than the ST ratio of umbilical artery, and it may show flow reversal at the diastolic section. It can be due to increased intracranial pressure because of applying pressure with the probe. The cerebroplacental ratio can be calculated by using this formula: pulsatility index of MCA divided by pulsatility index of umbilical artery, and it should be more than 1:1. If it is less than 1:1, it will be abnormal. The pulsatility index is another parameter to measure blood flow resistance. We can use it to calculate cerebroplacental ratio. It must also decrease over time. Here are some approximate values, some examples of pulsatility index. At 20 weeks, it is 1.97, and by 37 weeks, it has decreased to 1.15. A low resistance flow is abnormal. We will see high velocities. Here you can see the PSV is almost 80 centimeters per second, whereas in the normal case it is below 40 centimeters per second. And the ST ratio is very high, 8.57. This can be a sign of fetal growth restriction or anemia. The brain sparing effect causes this low resistance flow. It is an abnormality, and it is a sign of fetal growth restriction. The head circumference can be normal, but the abdominal circumference is decreased. This leads to compensatory mechanisms which lead to vasodilatation of the cerebral arteries and produces a low resistance flow. The peak systolic velocity is high, it is more than 60, whereas in the normal case it is below 40 centimeters per second. And even the end diastolic velocity is high, it is more than 20 centimeters per second, whereas over here it is very low, it is below 10 centimeters per second approximately. And the ST ratio is also high, it is 2.59.
Hello everyone, this is Dr. Sam, and today we will study fetal gender determination on ultrasound. Fetal gender can usually be determined around 16 weeks of gestational age. In some cases, it can be difficult to determine the gender at this stage because of fetal position that makes it difficult to visualize the genitalia properly. Here we have a male fetus at 17 weeks. It is a transverse view of the perineal region. We can see the penis and a small scrotal sac between the thighs. These are the thighs. This dome-shaped structure is the scrotal sac. And over here is a fetus of 16 weeks gestational age. We do not see the scrotal sac or the penis, but we can see the umbilical cord at this region. This cord can be mistaken for male genitalia, so always take care while scanning the perineum. It is better to wait before declaring the fetal gender. Here we have an image of 18 weeks. We can see the penis and the scrotal sac as well. This small dome-shaped structure is the scrotal sac. We can also see the bladder here. And over here we have an image of 19 weeks. In a female fetus, the labia will appear as 3 to 4 hyperechoic parallel lines in the perineum. These hyperechoic lines are helpful in determining the gender. The gender will be female. It is partially obscured by the shadowing due to the femur over here, but we can still see the labia. As the fetus grows, the genitalia become more prominent and we can see them more easily. Here is a 19 weeks male fetus. We can see the penis and the scrotal sac more clearly. This is an image of a female fetus of 20 weeks. We can see the labia. We can see 3 parallel lines, but in this image they are not appearing as lines. They are somewhat appearing as dots, but it is still helpful in determining the gender. At 24 weeks, the appearance of the labia is even more clear. We can see the hyperechoic parallel lines very clearly. Determining the gender becomes more easier as the fetus grows. Usually by 32 weeks in a male fetus, the testes will descend into the scrotal sac and they can be visualized. In this image, however, we do not see the scrotal sac, but we can see the male genitalia. And over here we have a female fetus of 31 weeks. We can see the soft tissues of the labia as well, along with the hyperechoic lines. This is an image of a 34 weeks old male fetus, and we can see the testes within the scrotal sac. Also there is some fluid outside the testes, the hydroceles. In the third trimester, such hydroceles are a normal finding. Here is an image at 35 weeks. We can see the male genitalia very clearly. We can see the testes within the scrotal sac. Hello everyone, this is Dr. Sam and this video is about fetal presentations on ultrasound. Fetal presentation can be seen in a longitudinal view. The cephalic presentation is the most common and an ideal presentation for normal delivery. The fetal head is directed towards the cervix. It will be seen on the right side of the image. The fetal body will be directed towards the fundus, that is the upper part of the uterus. The body is seen on the left side of the image in a longitudinal view. Fetal lie is the relationship between the long axis of the fetus and the mother's spine. In these images, a longitudinal view is taken. The fetus is also appearing longitudinally inside the uterus. So this is a longitudinal lie. The fetal spine is oriented parallel to the mother's spine. This is a cephalic presentation with an anterior spine. The spine is facing anteriorly. This is also a cephalic presentation. Regarding cephalic presentation, there are two orientations. The first one is cephalic spine posterior. The spine is seen in the lower side of the image in both longitudinal and transverse views. In the transverse view, the fetal left is on the left side of the image and fetal right is on the right side of the image. Here we can see the stomach on the left side of the image, so this is the fetal left. Similarly, the heart is also seen on the left side. The apex is pointing towards the left side of the image. The second orientation is cephalic spine anterior. The spine is oriented anteriorly. In the transverse view, fetal left is on the right side of the image and fetal right is on the left side of the image. The spine is seen on the upper side of the image, and here is the stomach, so this is the left side of the fetus. And here is the heart. The apex is pointing towards the fetal left. This is the left side of the fetus. The spine is seen on the top side of the image. Now we move on to breech presentation, in which the fetal head is directed towards the fundus and the fetal body and legs are directed towards the cervix. If this presentation is seen near the end of pregnancy, a C-section is preferred for delivery. Breech presentation has few types. The first one is a complete breech presentation. Both the hip and knees are flexed. We see folded legs and flexed hips directed towards the cervix. The fetal lie is longitudinal. In a longitudinal view of the uterus, the fetus is also in a longitudinal orientation. Breech spine posterior is an orientation of breech presentation. The spine is located on the lower side of the image in both longitudinal and transverse views. In a transverse view, the stomach is seen on the right side of the image, so fetal left is on the right side of the image and fetal right is on the left side of the image. And here we have a breech spine anterior orientation. The spine is seen on the upper side in the image. The fetal left is on the left side of the image. That's why the stomach is also seen on the left side. And fetal right is seen on the right side of the image. The next type of breech presentation is frank breech. It is the most common type of breech presentation. The hips are flexed and both knees are extended, directing the feet towards the fundus. The fetal lie in this presentation is also longitudinal. In a footling or incomplete breech presentation, one foot is directed towards the cervix. One or both the hips will be extended, but mainly we will see a foot right next to the cervix. In a transverse lie, the fetus is positioned horizontally across the uterus. Although this is a longitudinal view of the uterus, the fetus is seen in a transverse orientation. confirming that this is a transverse lie. In a phonic or cord presentation, the umbilical cord is found right next to the cervix. Color Doppler is very helpful in locating the umbilical cord. Hello everyone, this is Dr. Sam and this video is about amniotic fluid volume ultrasound. Amniotic fluid volume assessment is part of the fetal biophysical profile. It is evaluated around 28 weeks of gestation. Fluid volume can be assessed using amniotic fluid index or maximum vertical pocket method. In amniotic fluid index or AFI, the uterus is divided into 4 quadrants and a measurement of the deepest pocket of fluid that is free of fetal parts and umbilical cord is taken in each quadrant. The 4 measurements will be added together. For normal fluid volumes, the sum of these 4 values must be between 5 and 25 centimeters. The second method is maximum vertical pocket or MVP, in which a single measurement is taken from the deepest pocket of fluid, free of fetal parts and umbilical cord. This value must be between 2 to 8 centimeters for normal fluid volume. This image shows us a normal amount of amniotic fluid around the fetus. This image is of oligohydramnios, in which there is low amount of amniotic fluid. We can see a reduced amount of fluid around the fetus as compared to the fluid amount in the normal image. The AFI value will be less than 5 centimeters and MVP value will be less than 2 centimeters for oligohydramnios. Here is another image showing oligohydramnios. There is reduced amount of fluid around the fetus. Now we will compare normal fluid levels with oligohydramnios using amniotic fluid index method. This is quadrant 1. The deepest pocket measures 6.2 centimeters in quadrant 1 and over here is oligohydramnios. There is a small area of fluid. The quadrant 1 measurement is only 0.8 centimeters. In quadrant 2, the deepest pocket measurement is 2.5 centimeters for the normal fluid volume. In this image, the quadrant 2 measurement is 1.2 centimeters. It is another small pocket of fluid. In the third quadrant, the measurement is 1.8 centimeters. We can see a decent amount of amniotic fluid, whereas in case of oligohydramnios, we see very little amount of fluid, with the third quadrant measurement being only 0.1 centimeters. The last measurement is taken in the fourth quadrant. It is 4.4 centimeters here in the normal image. And in this image of oligohydramnios, we do not see any fluid in the fourth quadrant, so the Q4 value is 0. For the normal fluid volume, by adding the values of all 4 quadrants, we get an AFI value of 14.9 centimeters. And for oligohydramnios, it only adds up to 2.1 centimeters. In maximum vertical pocket method, the normal value is between 2 to 8 centimeters. In this image, the single deepest pocket measurement is 5.8 centimeters, so that is normal. And in oligohydramnios, we see a very small area of fluid. The measurement is 1.3 centimeters. In polyhydramnios, there is an abnormally large volume of amniotic fluid. The AFI value will be greater than 25 centimeters and MVP value will be greater than 8 centimeters. By general observation, we can see a large volume of amniotic fluid around the fetus. Here is another image of polyhydramnios. We see a large amount of amniotic fluid around the fetus. Now we will see polyhydramnios by using AFI method. The normal images are the same as previous ones. This case is of polyhydramnios. Quadrant 1 measurement is 5.6 centimeters. The quadrant 2 measurement is 8.5 centimeters. We see a large pocket of fluid. The third quadrant measurement is 6.9 centimeters. And the fourth quadrant measurement is 8.2 centimeters. The total sum of all four values is 29.2 centimeters. So this is polyhydramnios because it is more than 25 centimeters. By using maximum vertical pocket method, this fluid pocket is 11.5 centimeters. So it is polyhydramnios because it is more than 8 centimeters. In anhydramnios, there is complete lack of amniotic fluid. The placenta is stuck to the fetus and we cannot see fetal parts properly. No amniotic fluid is found. Hello everyone, this is Dr. Sam and today we will study twins ultrasound. Twins are classified as monozygotic or dizygotic based on the type of fertilization. In monozygotic twinning, a single egg is fertilized by a single sperm. This is further subdivided based on the number of chorionic and amniotic sacs. Its first subtype is monochorionic monoamniotic, in which there is only one chorionic sac and one amniotic sac. Only one yolk sac and one placenta will be present. The twins will be identical with same gender. No intertwin membrane will be seen between the twins. The second subtype is monochorionic diamniotic. It has a single chorionic sac but two amniotic sacs. Two yolk sacs will be found, but it will also have only a single placenta. The twins have the same gender. Both of them will be either male or female. An intertwin membrane will be seen between the twins. It is made of two layers of amnion and usually measures less than 2 millimeters. Sometimes this membrane is very difficult to see. In dizygotic twins, two eggs are fertilized by two different sperm, and these twins will be fraternal twins. Dichorionic diamniotic is its subtype, in which there will be two chorionic and two amniotic sacs. Similarly, they will have two yolk sacs and usually two placentas as well. The twins' gender can either be same or discordant, that is, one twin can be female and the other twin can be male. The intertwin membrane will be thick because it is made up of two layers of chorion and two layers of amnion. You can see that it is much thicker than the intertwin membrane in monochorionic diamniotic twins. The T sign is an indication of monochorionic diamniotic pregnancy. This thin membrane attaches in a T-shaped configuration. It looks like a T. The twin peak sign, also known as the lambda sign, is an indication of dichorionic diamniotic pregnancy. thick triangular shaped chorion will be seen abutting the intertwin membrane. Here are more images. This is the T sign and this is the twin peak sign. The triangular shaped chorion is seen here. Now we move on to number of placentas. These are monochorionic, monoamniotic twins. We see only one placenta that is supplying both the twins. Dichorionic diamniotic twins usually have two separate placentas, but in some cases there is fusion of the placentas if they are close to each other. They will appear as a single placenta. Measuring amniotic fluid volume is important. For twin pregnancies, the maximum vertical pocket method or MVP method is used, in which the deepest vertical area that is free of fetal parts is measured to assess amniotic fluid volume. The normal range of MVP is from 2 to 8 centimeters. Oligohydramnios occurs when the MVP value is below 2 centimeters. You can see a very small amount of amniotic fluid here. In polyhydramnios, there is excessive amount of amniotic fluid. The MVP value will be greater than 8 centimeters. These are dichorionic diamniotic twins. The fetus that is expected to be delivered first is the presenting fetus and is labeled twin A. It will be close to the cervix. The other twin is labeled B. Vanishing twin occurs when an embryo that was seen normally on earlier ultrasound disappears on future ultrasound scan. The other twin has normal cardiac activity and grows normally. The vanishing twin will be smaller in size and will have no heartbeat. In this image we see a small empty sac. The vanishing twin is ultimately absorbed and only one normally growing twin is left behind. Twin-to-twin transfusion syndrome is a complication found in monochorionic twins. It occurs due to abnormal vascular connection in the placenta. It has many features. In the first trimester, we may start to see a discordance between CRL of the twins. A 10% difference in CRL measurement can be a sign of an impending twin-to-twin transfusion syndrome. The twin B is smaller than twin A. A nuchal translucency discordance of greater than 20% is another sign of twin-to-twin transfusion syndrome. Here you can see a significant difference between NT values. Pulsed wave Doppler is very helpful in diagnosing twin-to-twin transfusion syndrome. Regarding ductus venosus, we may find A wave reversal in at least one of the twins. We will see the A wave below the baseline. The normal A wave is above the baseline. Intertwin membrane folding may also occur, and it may be a signal of twin-to-twin transfusion syndrome. Twin-to-twin transfusion syndrome has 5 stages. In stage 1, polyhydramnios is seen in one twin and oligohydramnios is seen in the other twin. The twin suffering from polyhydramnios is the recipient twin and the twin suffering from oligohydramnios is the donor twin. Stuck twin can occur in the donor twin. Due to very low amount of amniotic fluid, the donor twin may get attached to the uterine wall. It will have a fixed position. This is the intertwin membrane resting above the stuck twin. In stage 2, the donor twin will have a small or non-visualized bladder. This is in association with oligohydramnios. The recipient twin will have an enlarged bladder along with polyhydramnios. Here is another image showing non-visualization of bladder in donor twin, and the bladder is visualized in the recipient twin. In stage 3, abnormal Doppler values will be seen. The umbilical artery SD ratio will be elevated. Abnormality in A wave of ductus venosus can occur as well. In these images, there is A wave reversal in twin A and a deeper A wave in twin B. For umbilical artery, reversed diastolic flow may be observed. The diastolic flow is seen below the baseline. Fetal hydrops is in the 4th stage of twin-to-twin transfusion syndrome. Excessive fluid collection will be found in at least 2 components. Here we see ascites and soft tissue edema. It usually occurs in the recipient twin. These components include pericardial effusion, pleural effusion, ascites, generalized edema, enlarged placenta, hepatomegaly, and polyhydramnios. Skin edema causes skin thickening. In this image, we see ascites as well as pleural effusion. Here we have pericardial effusion and cardiomegaly. We see an enlarged heart and accumulation of pericardial fluid. In the final stage of twin-to-twin transfusion syndrome, death occurs in either twin. Twin embolization syndrome is a rare complication in the surviving twin after the death of co-twin. The damage is actually ischemic rather than embolic. Most commonly, brain injuries are involved. Here we see fluid in the cisterns of the brain, suggesting brain injury. Brain injuries include intraventricular hemorrhage, Hydrocephalus, or Porencephaly. Abdominal abnormalities include gastroschisis, in which there is a defect in the abdominal wall, which will cause herniation of usually bowel and other organs. Here the small bowel is seen outside the abdomen. The surviving twin may suffer from hydrothorax, which is basically a large pleural effusion. Acardiac twin is an abnormality in which a twin grows without a functioning heart. It is also called twin reversed arterial perfusion sequence or TRAP sequence. It is a monochorionic twin abnormality. Doppler analysis shows flow reversal in umbilical artery. The direction of flow is towards the acardiac twin instead of being towards the placenta. Acardius annifus is the most common type of acardiac twin. In this type, the legs will be formed normally, but there is absence of normal head and brain structures. In Acardius anceps, partially formed limbs and some organs can be seen. Acardius amorphous contains unrecognizable structures and organs. We cannot see any normal organs in this acardiac twin. Acardius accormus is the rarest type of acardiac twin. Only fetal head is formed. Umbilical cord entanglement can occur in monochorionic monoamniotic twins. The cords of both the twins form a knot as they entangle. We can confirm an umbilical cord entanglement by using color Doppler, which enhances its appearance, and we can clearly see the entwined umbilical cord. On pulse wave Doppler, reduction in end diastolic flow is seen. You can see a notch in the end diastolic waveform. Conjoined twins refer to fusion of fetal twins. The twins are attached to each other. You can see the fusion of the chest and abdomen. The head level of both the twins will persistently remain at the same level. In most of the cases, the twins will be facing each other. Thoracopagus refers to twins that are conjoined at their chest, and Omphalopagus refers to twins that are conjoined at the abdomen. This image has fusion of both the chest and abdomen, so these are named thoraco-omphalopagus twins. Craniopagus refers to fusion of any part of the skull of the twins. Here is the fusion of the skull between the twins. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.